for today. The title of this talk is Addressing Stigma and Providing Care for People with Perinatal Opioid Use Disorder. I'd like to welcome Dr. Kantrowitz-Gordon. He is an associate professor at the University of Washington School of Nursing, Seattle. His primary area of impact are nursing care for perinatal opioid use disorder and diversity in midwifery. Funded by the Washington State Healthcare, he led multidisciplinary team to improve care for perinatal opioid use disorder in Washington through provider education and dissemination of best practices. He serves as the deputy editor of the Journal of Midwifery and Women's Health, works clinically as a nurse midwife for Providence Medical Group in Everett, Washington, and serves on the Washington State Maternal Mortality Review Panel. And actually, before I turn it over, I want to mention to all of you, there is a free best practices opioid use disorder video you can use. You can share it with your staff as an in-service. It's 42 minutes, and it features Dr. Kantrowitz-Gordon and nurses serving this population, and stories from a mother who had a substance use disorder, and sort of her life story is interwoven through this. So maybe Maureen or Nancy can pop that link into the chat. Please use this for an in-service. Share it with your colleagues. Send it out. It's free, okay? And it talks about eat, sleep, and console as a best practice. So with that, I'm going to turn this over to Ira for the presentation. And I'm going to stop sharing. And there we go.
Okay, thank you, Monica. It'll just take me a second to get my screen share started.
Yeah, and while you're doing that, Nancy or Maureen put in the chat the video. So click on that link, bookmark it, and use it to educate other colleagues in your program.
And I also included a link to that in my slides.
Oh, awesome. And we will be sending slides out with a link to the talk today. So feel free to share those with your colleagues.
Okay, and can you see my slides? Okay, wonderful. So let me go back, actually. There we go. So thank you so much, Monica, for the warm introduction. And I'm so happy to be here to talk about a topic that I care deeply about, which is looking at stigma and the care of people with perinatal opioid use disorder. I became interested in this topic even when I was a nursing student. I did my senior practicum in a substance use treatment center, and they served a lot of pregnant people. So it was my early introduction to the importance of providing really respectful care to people who are affected by this condition. So to get started, I'd like to just get us on common ground on how common is it that we have people with opioid use disorder in general, and then during the perinatal period. So if you've been paying attention to the news, you might have heard that we exceeded 100,000 overdose deaths in the United States from substances starting around 2020, 2021. And you can see that it appears to be still going up, which is perhaps a consequence of the COVID pandemic on top of an already growing problem. And then if we look at opioid overdose deaths in particular, there's actually been a pattern of how people have been achieving an overdose. Over the last 20 years, this has really changed. It's described as in three waves. There was the first wave was initially prescription opioids, medications like OxyContin, and then that's shown in the grayish blue color. Then there was a peak of heroin use starting in around 2011, which has plateaued somewhat. And then more recently, we see a rapid rise in synthetic opioids, in particular fentanyl, which has really skyrocketed, and the number of deaths has risen dramatically, probably because fentanyl is such a potent opioid. It doesn't take much for somebody to achieve an overdose. Now, as a participant in the maternal mortality review panel, I've been part of the reviews of the pregnancy-associated and related deaths in Washington State. And what we found in the most recent completed review, that something like 15% of deaths related to pregnancy in terms of timing, either during pregnancy or the year afterwards. So 15% of those during 2014 to 2016 were from overdose, which was also primarily opioids. Then if we look at the overall, in the year 2020, the opioid deaths by age group, you can see that more than half of the people who have died from overdose are in the reproductive age between 15 and 44 years old. So it's a real setup for pregnant people and postpartum people to be exposed to this problem. Then if we take a closer look at people who are pregnant who actually have a diagnosis of either opioid use disorder, or their newborns receive a diagnosis in the medical record of neonatal abstinence syndrome. And a little bit later, I'll talk about the language around neonatal abstinence, and that there's actually a better language for that. But this is how the study looked at diagnosis codes in health records. And you can see there's a parallel increase in both conditions that also parallels the overdose deaths. So we've got a problem that is impacting and growing for the perinatal population. And this is showing a rate per 1,000 birth or delivery hospitalizations. And you can see that it's, at least in this graph, it's approaching 1% overall. But if we look at across the United States, we can see that there's a wide geographic variation, where in some states it exceeds 1%, so more than 10 per 1,000 births. There will be a diagnosis on the health record of neonatal opioid withdrawal, that the fetus was exposed to opioids during pregnancy to the extent that it was then, he or she then went through withdrawal afterwards, after the birth. So next, I'm going to move into talking about stigma and how this impacts care. And if we start off, I think it's important to really understand what exactly is stigma. Historically, stigma was an actual physical mark on the body of criminals or other undesirable people that was imposed by people in power. So for example, in July, I actually went on a trip to Europe, and in Germany, they had this quite interesting medieval crime and justice museum. And this was a picture I took of some of the brands that they had in that museum, where they would actually brand criminals historically. Their bodies would be marked that they were bad people. And of course, in Germany as well, there's the experience of the Holocaust, where Jewish people and others were forced to wear armbands to identify them as members of marginalized, oppressed, undesirable groups. Now, in more the 21st century, we have a more nuanced understanding of stigma, that it's less about the individuals and it's more about the community, the people in power who are creating stigma. So it's not just that people are stigmatized, but it's a process where there's sociological and cultural influences that create these labels of some people as being abnormal, shameful, or otherwise undesirable. And as it relates to the stigma of mental health, which I will then apply to substance use disorder, Corrigan developed a model where there's actually two kinds of stigma. There's the public stigma, and then there's the self-stigma. So with public stigma, these are the processes whereby the culture, the social environment, the public will impose a stigma upon people, and that process relates to cues. How do you know that somebody is a member of a stigmatized group? And then based on that, public perceptions through stereotypes and prejudices will enter the minds of people interacting with members of a stigmatized group. And ultimately that leads to discrimination, of people being treated differently. And the consequence of that, which is really important when we think about what happens to people who are stigmatized, is that they lose social opportunities through different mechanisms. It might be that they cannot get certain jobs. For example, somebody with a criminal history may not be hireable. Housing may be restricted for people based on their stigmatized group membership. Healthcare access is very important for substance use disorder, because sometimes people, for various reasons, cannot access healthcare. And then they may, we'll talk a little bit later about incarceration. Because of the fear of being treated differently, often people who are in stigmatized groups will be isolated and under extreme stress. Now, one of the unfortunate consequences of public stigma is that often people in the stigmatized group will internalize the stigma and believe it themselves. So the process around that is that then they will believe the same prejudices about themselves. It leads to low self-esteem and even shame. People are telling me that I'm a bad person, and so I feel that as shame. And what that leads to is decreased self-efficacy, so that a person with a stigmatized identity, like being someone who has a substance use disorder, will then maybe have less ability to feel like they can help themselves, that they can obtain resources, that they can get care that they need. So all of that combines to lead to the possibility of treatment avoidance, where somebody cannot access or does not feel like they can access the care that they need. It's also important to understand that when somebody is stigmatized by one particular condition or identity, they may also have intersectionality with other identities that will further stigmatize them. For example, in the 1980s into the 90s, there was this almost hysteria around the exposure of fetuses and newborns to crack cocaine, and they were described as crack babies or crack kids. And it was a crisis that was not evidence-based, and the impact of cocaine use on the fetuses and newborns was way overblown. But one of the intersectionality here was that it was largely attributed to Black families. And so it was a double stigma of being Black and being having a substance use disorder. We also see that, of course, gender plays a large role here, that there's this high societal expectation that about what it means to be a good mother. And certainly having an illness like substance use disorder does not fit into that model. There's also this idea in the picture on the left. This was an actual advertisement or public service announcement in Britain from their National Health Service, where there's this idea that the mother, the pregnant person, is really only important because of the child that they are generating, that they are gestating. And again, this relates to ideas about values and who's important, and that children are innocent, and the implication is that their parents are not innocent and that they are guilty for what happens to their children. So this stigma that comes with perinatal opioid use disorder leads to some beliefs that I've outlined in this table that are that I'd like to spend a little time on. And these beliefs are not congruent with what we know to be true around the disorder. So the first one is, why do pregnant individuals use opioids? The myth is that it's a selfish, immoral choice, that it comes from pleasure seeking to get high. But as it turns out, the vast majority of people who have an opioid use disorder, they are in the point of the disorder where they are not using to get high. They are using because of the strong cravings, and they are trying to reduce withdrawal symptoms. So there's really no pleasure in it. Also, it's important to understand how how people end up with substance use disorder does not necessarily relate to choices people make, but often it relates to chronic pain conditions. And there's a strong linkage between substance use disorder and child and adult trauma, whether that's sexual trauma or other kinds of trauma. And this is not something that people choose for themselves. It is something that happens. Another question that sometimes people ask about people with opioid use disorders, whether they question their fitness as parents. And the myth is that it's an automatic no, they are not fit as parents. These children should be taken away and, to protect them. What we know is true, and I've seen this clinically in the care of patients with perinatal opioid use disorders, they care deeply about their children. And any difficulties they have with parenting really do not stem from substance use, but rather from them not having access to the societal social supports that they need. So if there's anything that's lacking in fitness in general, it's not the parents themselves, but our systems that are unfit and do not support parents the way they need. Another question that a lot of people have is, what are the impacts of opioids on fetuses and newborns? And the myth around this is, first of all, that a baby is born addicted to opioids, and a deeper understanding of addiction relates to behaviors. And newborns do not have the behaviors associated with substance use. They are not making choices or losing their jobs because of addiction or anything like that. So the idea of them being addicted is just not true. It's more that they go through withdrawal syndrome, which we'll talk a little bit more about later. The other myth is that opioids relate to birth defects, and if there is any connection to birth defects, it is very weak, if non-existent. And then there's this idea that opioids cause growth restriction for fetuses. While there may be a weak relationship between substance use and growth restriction, it likely relates less to the substances involved themselves and more to all the social contexts of substance use, the poverty, the loss of income, poor nutrition, and everything that's a consequence from substance use being marginalized and not being adequately treated. So any relationship with child development outcomes also are really hard to attribute directly to substances and are much more likely to the social contexts that come along with substance use. And then finally, I'd like to point out that opioids likely have much less effects on fetuses and newborns than legal substances such as alcohol and tobacco, which are known to have some direct effects, particularly alcohol. Another question that people ask is, what is the best treatment for opioid use disorder? And one of the myths out there is that complete abstinence from opioids and all substances is what is necessary. And what we know is actually we don't recommend that. If a pregnant person comes to me for prenatal care and they disclose that they are using opioids regularly, I do not tell them to stop. Instead, I help them get treatment with either methadone or buprenorphine. That is the standard of care, and that is the primary treatment. And we'll talk a little bit more about the language around the treatment of opioid use disorder. And then finally, how to treat pain. Somebody, if they already have opioids in their system, what's the best way to take care of their pain? And one of the myths around that is, well, they already have opioids, so they don't need pain treatment. Or perhaps they are drug seeking and they don't have, they don't have pain, or perhaps they are not morally deserving of treatment because of the choices they've made. Not my language. The facts are that if somebody is taking buprenorphine or methadone to treat opioid use disorder, and then they have surgery or other conditions that give them pain, that is not going to be adequate to treat their pain, and they may need additional medications or other ways to address their pain. And certainly everyone deserves treatment for pain. Another major consequence of the stigma of opioid use disorder is incarceration. And we've had in the United States what we've called the war on drugs, which is largely the war on substance using individuals. And in particular with pregnancy, there's a nonprofit called National Advocates for Pregnant Women, which is a group that defends pregnant women who are susceptible to incarceration and arrest for crimes that they would not be arrested for if they were not pregnant. And they've documented more than 1,300 cases where a woman was being pregnant was what got them into legal trouble. In addition to, for example, substance use, that if they had not been pregnant, they would have not been incarcerated. And this is a really sad and unjust situation that we have throughout the United States, in some jurisdictions much worse than others, where the belief is that if they are thrown in jail, then it will stop substance use, it will protect the fetus. And from a public health standpoint, this is the absolute wrong approach. It drives people underground. Putting people in jail does not actually stop them from using substances, because drugs are easily and widely distributed in prisons and jails. So this is completely the wrong approach, and it just further stigmatizes substance use, keeps people from getting the help that they need, and it ruins people's lives from all the consequences of incarceration. Now, there have been some studies published that look at, actually talk to birthing parents and looks at what their experience of stigma is around the care that they receive in the hospital, in particular around after the birth, when their newborn may be going through withdrawal from opioids. And some of the challenges they see are they have shame and guilt from watching their infant withdraw from opioids. They feel really judged and stigmatized by the nursing staff. And they really struggle to build trust with the nurses. There's this barrier between them. In the work we did with through the Washington State Healthcare Authority, we also interviewed, had focus groups with people impacted by perinatal opioid use disorder. And when we asked them for their priorities for how to help, one of their top priorities was doing something about the stigma of addiction, treatment, and recovery. Was one of their highest priorities. This trust issue that we see between pregnant people with opioid use disorder and health professionals is what I called well-earned mistrust, that they have really good reasons not to trust us. They fear involvement of child protective services, criminalization, like I just talked about. There are situations where people are asked or somewhat coerced into having their urine screened for drugs, and all the consequences that happen from having a positive screen. Perhaps they will get reported because of that. There's also a trust issue around misinformation. Remember all those myths that I went over a few slides ago? Well, some of those myths are promulgated by healthcare professionals. And so somebody with perinatal opioid use disorder may ask their provider and get about a question and get one answer from their provider, a different answer from the nurse, other information that contradicts from the media, from Google searches, and so they don't know who to believe and who to trust. Another big issue is undertreatment of pain, that pain in people with opioid use disorder is discounted, that they're believed to be drug-seeking, and their reports of pain are not respected. And then finally, misattribution of normal symptoms to drug use. For example, I remember in one of the focus groups, one of the participants mentioned how they had a 3-day labor, and postpartum they were really, really tired, and they were having trouble staying awake. And that is so normal for anyone who's had a really long labor, but the nurse accused her of using drugs in her hospital room, and that's why she was unable to stay awake. And that it's really hard to develop a therapeutic relationship when you have those kinds of misunderstandings and accusations going on. And here's a quote from one of our studies where a parent with opioid use disorder said, "It's like people actually miss doctor's appointments, things like that. But if you miss a doctor appointment and you're a drug addict or recovering drug addict, it's the end of the world. It makes parents fear seeking healthcare for their child." That we excuse in clinics. It's okay when somebody misses an appointment now and then, but if somebody has an opioid use disorder problem and they miss an appointment, they are non-compliant, they're problematic patients, and they may even get discharged from care. In another study, we looked at nurses' stigma and bias, and we asked them how they feel about taking care of people with perinatal opioid use disorder. And here are a couple of quotes from nurses very honestly describing their feelings about caring for this population. And one said, "It's difficult to work with mothers who are unapologetic to how their choices have affected their child, mothers who do not care about the consequences." That single sentence is just full of assumptions and judgments about patients. And then another nurse really struggled with her own feelings, despite desiring to provide good care. "Dealing with my own emotions is hard because I truly believe they deserve the best possible care, but I can't help sometimes and judge their history of substance abuse." So here you can see from just these two quotes how stigma and bias is really alive in the minds of these nurses. We also looked at some quantitative measurements of stigma. We used a scale that has several statements that the participants would answer with how much they agreed with them, and pulled together they would show a level of stigma. And what we found was that there was a negative, fairly strong negative correlation between someone's self-identified stigma level and their compassion satisfaction, which is the satisfaction, professional satisfaction that somebody gets from providing compassionate care to somebody with perinatal opioid use disorder. So the higher the stigma, the less compassion satisfaction that they had. And then if we looked at both the stigma and compassion satisfaction in the care of people with substance use disorder and different situations. So for example, in general, or providing general care or providing parenting support, breastfeeding support, providing care for people with trauma histories, and then caring for infants going through opioid withdrawal. And we can see that the stigma was negatively correlated with comfort in providing care, whereas compassion satisfaction, that feeling good about providing compassionate care, was positively correlated. Interestingly, the weakest correlation between from stigma and compassion was with the infants. So for whatever reason, the infants were less impacted in the minds of the nurses by stigma, perhaps because of that myth about the infant being innocent and the parent not being so. Now, a little bit about language. So language is really, really important because it not only reflects stigma and our underlying beliefs, but it has consequences for reinforcing stigma. So we have language with stigma and the preferred language. So labeling somebody with their disease is evident in addict, calling something an addiction, using the word abuse either as a substance abuser or substance abuse, or even something as obvious as junkie. All of these are highly stigmatized. And really what we prefer is person first language. Says, we have a person with opioid use disorder. And one of the analogies I like to remind people of is that if somebody has a diagnosis of cancer, we don't call them cancerous. We call them a person with cancer. So it should be the same way with opioid use disorder. The language of clean and dirty, whether it's a clean urine or a dirty urine, really that's so stigmatized. And if somebody has a urine toxicology screen that is negative, they might be in remission from substance use. A habit, the word habit, it's not a habit, it's a disease. So let's just call it what it is, substance use or substance use disorder. Now, the older language, neonatal abstinence syndrome, like I mentioned before, newborns can't abstain. They don't really have choices around use or misuse. Instead, it's a withdrawal syndrome. Treatment of opioid use disorder, the first line treatment is medications like methadone or buprenorphine. But the older language of medication-assisted treatment, or MAT, is being replaced by just calling it treatment, because the idea that it's treatment assisted by medication suggests that it's not enough, that it's not the main treatment. And our understanding is that that language minimizes and presents a conflicting message around the use of those kinds of medications. So let's just call it treatment. We also try to avoid saying it's opioid substitution, because that implies that methadone and buprenorphine are also bad, that there's something wrong with them, that we're substituting one drug with another. And then finally, let's avoid calling or labeling patients as non-compliant or resistant. And when we talk about them or document around shared decision-making, we should give them agency and talk about how they made a choice not to go along with a particular treatment decision, or maybe they were ambivalent about their choices. Let's use language that's respectful. And all of this language matters because they've done studies that use of stigmatizing language actually will lead to more negative judgments by providers. So if we speak in a certain way that's more respectful, it affects us as professionals internally, in addition to improving how patients feel from the way we talk about them and the language we use with them. So it benefits both us and our patients to use respectful language. And studies that have asked people with opioid use disorder whether, what kind of language they prefer. In general, they prefer people first language, like we talked about. Now, the one exception is that it's well established in 12-step programs to use the word addict. And that now, while they may use that word in that context, we as professionals should probably avoid using it when we're talking about it. And I think it's really important for us to really think about our own biases and our own assumptions. So when we take care of somebody with substance use disorder, we should really ask the question, why do we think this patient has a substance use disorder? You know, what in their history led them to this situation? When somebody has a situation where they have pain and are asking for treatment of their pain, we should really think about the question, you know, do we believe whether they are in pain? And the answer should almost always be yes, we believe that they're in pain, because pain is such a highly subjective experience, and we need to listen. And then think about our own personal experiences with, you know, maybe with substance use, past patients, family members. How does that influence how we interact with our own patients? And then finally, what does a person with OUD look like? And what I would suggest is just look in the mirror, and that's what somebody with OUD looks like, because it could be anybody. There is no look, there is no way to identify somebody just by appearances. So briefly, I'd like to talk a little bit about the that often people with opioid use disorder and substance use disorder have, both now and in the past, incredible amounts of life stress. That they have housing instability, they may have had past or current incarceration. Substance use has impact on jobs and relationships, and for most of them, their pregnancies are unintended, that they did not try to get pregnant. There's another myth out there that people with substance use disorder will intentionally get pregnant in order to access services. And that's not true. There's also a large percentage of people with substance use disorder that have other comorbidities, other mental health conditions, such as depression, bipolar, schizophrenia. You can see the relative risks are listed here of having those comorbidities. In some studies, more than half of mothers with substance use disorder had an additional psychiatric condition or diagnosis. And then certainly tobacco use is highly common with pregnant people with opioid use disorder. Trauma is extremely common for people with substance use in pregnancy, both current and past, and that can be childhood trauma, trauma that continued into adulthood, intimate partner violence, structural violence, so violence while accessing healthcare or violence from the police, and then transgenerational trauma, trauma that was transmitted from one generation to the next. Many of you are probably familiar with the ACEs study. That's ACEs stands for Adverse Childhood Experiences. And the original study that looked at the relationship between ACEs and health found a strong relationship between the number of ACE categories that somebody reported and their prevalence of either alcohol use disorder, having ever used illicit drugs, or ever injected drugs. And you can see as the number of categories goes up, the prevalence of those conditions go up as well. So you can see that in the red boxes here, that as you go down in the table, the percentages go up. So to wrap things up, I'd like to, now that we've done a deep dive in the problem and the context of perinatal opioid use disorder, I'd like to suggest 6 steps that we can all take to improve care. So one of them relates to screening for substance use, and we should be using universal screening rather than selective screening, that we should screen everybody who's pregnant or maybe considering pregnancy. There are validated, simple screening tools. And when I talk about screening, I'm not talking about biological tests or urine tests. I'm talking about questionnaires, paper or interview. And so there are various screeners out there. I've given an example here of one that's the 5 Ps for asking questions about parents, peers, partners, past and present. And it's a simple yes/no set of questions. Now, this is in contrast to biological testing or urine toxicology screening, which looks at the presence of drugs in the urine. This is a way to test people that is fraught with all kinds of difficulties and challenges. First of all, there are consent issues. One should never do this test without verbal, if not even additionally written consent, which includes talking about the consequences of positive results and why are you doing this urine test in the first place. That could be a whole lecture just to talk about testing people. So I suggest using very extreme caution when you decide to even broach the subject. There are challenges with urine tests that there can be both false positives and false negatives. And what are you going to do about it if somebody tests positive? And what are the consequences of testing in terms of driving people away from care? As a prenatal care provider, I would much rather have someone stay in care and I not know that they have a substance use disorder, rather than my finding out and then they leave care, because then they're not getting anything. Okay, the second care strategy is work on developing trust. First of all, be patient. It takes time. It's not going to develop the first time. Perhaps you meet with somebody. And one of the ways you can build trust is to use respectful, non-stigmatizing language. And then I always try to find something positive to say every time I meet with somebody. That's true for all patients, but especially true for people with substance use disorder. Acknowledge the positive. It could be something as simple as, I'm so glad you're here today. I'm so glad you made it in for care. Thank you for feeling comfortable to talk about these issues with me. And then find ways to show how much they care about their fetus or their baby. You should care for your fetus by enrolling in prenatal care, by taking your vitamins, but there can be any number of things that you can say to somebody that shows validation and acknowledgement. It's important to develop clear guidelines on clinical care related to substance use disorder and opioid use disorder in pregnancy. And this will help avoid intentional and unintentional biases in the guidelines, because one of the real challenges we've noticed in research is that there is a disparity in who gets reported to Child Protective Services, and that there is a racial bias towards reporting Black and people of color into child protection. And so if we have strong guidelines that say exactly how and when those kinds of reports should happen, then the likelihood of those kinds of biases will go down. But there can also be unintentional biases that will lead to disparities in impact. So it's important to, when developing guidelines, to be very open to examining how those unintentional impacts can also happen. Also, as part of guidelines, anyone who has opioid use disorder or even has a prescription for opioids, even if it's in a different context, that they should be receiving a naloxone prescription. Going back to the beginning of this talk, we need to be helping prevent overdoses and overdose deaths. And then finally, when you have guidelines, it's important to be transparent with patients about those guidelines, and they should not come to them as a surprise. Next treatment recommendation or care recommendation is that we should be treating opioid use disorder with medications. So it should be a consistent message that buprenorphine or methadone are standards of care. They are the main treatment, and that behavioral treatments are an adjunct to medication treatment, and that these medications are safe for the fetus and newborn, and withdrawal is not safe for the fetus and newborn. Along with treating with medications, we need to increase access to treatments. So we need to develop the systems that will support that. So that includes a co-location of prenatal and opioid use disorder treatment services, which is a wonderful approach where somebody goes in for prenatal care and they get their medications in the same location. When somebody is getting referred for treatment of OUD, a warm handoff is really much better than just giving the patient a phone number and then expecting them to call. We need to increase support for prenatal providers becoming prescribers of buprenorphine. The DEA is starting to relax a little bit their requirements, but it is probably easier to get heroin and fentanyl on the street than it is to find a prescriber, to get your prescriber, your care provider, or find a prescriber who will get you buprenorphine. So we need to fix that problem. And then finally, there are situations where people are already hospitalized or being seen in a hospital, and that is an opportunity to initiate buprenorphine treatment or methadone treatment. So we need to remember that when we have somebody in our care, how can we help them get started rather than referring them out? And then most importantly, neonatal opioid withdrawal syndrome is a condition where the newborn goes through withdrawal symptoms, perhaps because they are no longer receiving the opioids that they got through the placenta. The main treatment for that should be parenting support. Historically, symptom management was the approach. Somebody was scored with a Finnegan score to see how bad the newborn withdrawal symptoms were. And then if they got high enough, they were whisked off to the NICU and treated with morphine. Instead, a lot of hospitals are moving towards an approach where it's called Eat, Sleep, and Console, that looks at helping the newborn get its activities of daily living accomplished. And newborns have very simple activities: eat, sleep, and to be consoled. And if they can manage that, then they don't need symptom management. And this approach sends a really strong message that to the parent, who can be most responsible and present to help the newborn eat, sleep, and be consoled, is the treatment for now. The parent is the treatment. And that's really the antidote for stigma, that parents are, instead of the problem, they are a solution. Part of the way we can help accomplish this is longer postpartum lengths of stay to support parenting during this vulnerable time of possible withdrawal. And 5 days is an optimal time to have people stay in the hospital, get that parenting support, promote good contact between the birthing parent and the newborn. So I'm just gonna, because I know we're running out of time, I'm going to skip quickly through some of these slides. So these are some of the symptoms that an unconsoled infant may experience related to opioid withdrawal. Here's what the Finnegan scoring looks like. It's scoring the different symptoms that are possible. But the non-pharmacologic approaches that we use to help parents include empowering the parents, swaddling or skin-to-skin for the newborn, breastfeeding provides that skin-to-skin contact as well as comfort, and then rooming in, of course, very important. Keep the parents with the newborn as much as possible. So here's a little bit more detail about Eat, Sleep, and Console. Eat should be appropriate for the newborn's age. Sleep is the ability to stay undisturbed asleep for at least an hour with or without being held. and then consoling within 10 minutes. Can the baby be consoled? If not, then other behavioral approaches may be necessary, or you might need to switch to a second caregiver if the primary caregiver is feeling just a little bit stressed. And that's part of the support that can be given. Here are some examples of counseling support interventions, using calm voice, a hand on the abdomen, helping the baby bring their arms and legs together, holding, swaddling, gently rocking or swaying, and then non-nutritive sucking can also be helpful. And you can tell that an infant is consoled by their behaviors. Their eyes might be open, their movements are less, they appear calm, and their breathing slows down. Now, I do not have time to give justice to co-regulation, but this comes out of a program from the Barnard Center and called PFR, or Promoting First Relationships. It is an excellent program. I highly recommend it. It relates to how, as caregivers, as professionals, we can help the parents or caregivers work with their children, and how we can support that relationship. And the idea is co-regulation, that the adult caregiver is sensitive and responsive to the needs of the infant, and there's this communication back and forth between them. And I know I'm running out of time, so I'm going to skip ahead, but the relationship between the parent and the infant is contained if the parent can receive and understand the emotional communication, and that there's this back and forth between them that leads to a stable environment between them, that the infant is soothed, the parent is calm, and they communicate back and forth. But if the parent is unable to contain, if the parent is feeling scared or dysregulated or overwhelmed, then what we learn in promoting first relationships is that there can be a go-to person that helps the parent and helps contain the parent, so then the parent reduces their stress and is able to help the infant. So in this, we call this the parallel process. The helper person can listen to the mother's or the parent's distress and pause, reflect on their own feelings, reflect on the mother's feelings, and wonder and ask these questions: what does each person need? And then respond and help. Now, if the go-to person is also unable to contain, let's say that you're a nurse, you're taking care of a family, and you're finding that taking care of them is stressing and you're not able to help them, then you need your own go-to person to help. And then hopefully that'll help you calm down. You'll be better able to care for your patients, which ideally is not just the mother or the birthing parent, but both the whole family unit, and so that you can help them work together. So here is the link to that 40-minute YouTube video that's freely available. It has really some really wonderful segments with a nurse and the patient that she took care of. It was amazing that we were able to get a hold of both of them and hear how they interacted and how they had a positive relationship that was mutually supportive. It's a tremendous role models for how to provide ideal nursing care. And then there's the link to the Promoting First Relationship programs, which I highly recommend. I did the PFR in pediatrics 2-day course, which was really one of the best courses I've ever taken and really helpful as a care provider. So just to wrap up, key points: understanding our biases and stigmas is necessary to remove them as barriers to effective care. Medications are the best treatment for opioid use disorder, but non-pharmacological treatments are the best approaches to helping newborns at risk of opioid withdrawal. And really, the mother or parent is the treatment in those circumstances. And if we look at care from a relationship-based approach, there are so many benefits for engaging people in treatment and in care and being effective in our therapeutic relationships. So I'll pause here for any questions. And I'm certainly, I don't know if we're able to go past the hour. I'm certainly able to, if that's an option.
Yeah,